One clogged artery can change your life forever. That is CAD. Coronary Artery Disease. What is it? Coronary artery disease is the narrowing or obstruction of coronary arteries due to the atherosclerosis. The accumulation of lipid-rich plaque occurs in the arterial wall. The arteries occlude by the obstruction due to the lipid occlusion, causing the blockage of blood to the vessel. Why it matters? CAD is the first cause of death in worldwide, responsible for more than 9 million deaths annually. Clinical spectrum where the stable angina, unstable angina, end-STEMI and STEMI occurs. Causes of CAD. Atherosclerosis is the primary cause of CAD. LDL deposition in the arterial intima triggers the chronic inflammation and plaque formation. Next, the thrombosis. Plaque ruptures exposes to the subendothelial collagen, activating the platelets and coagulation cascade. Coronary vasospasm, where the fringe metal angina, the transient spasm of coronary arteries, often at night without fixed obstruction, occurs. Endothelial dysfunction due to the impaired nitric oxide production reduces the vasodilation and promotes the pro-inflammatory state. Reduced vasodilation causes the pro-inflammatory state in the CAD. Now let us learn the clinical features of CAD. Mnemonic for it is pressure, where P stands for pain. Pain in chest, that is chest tightness. R is radiation, that is the radiation of pain to the jaw or the arm. E stands for exertional trigger. S stands for sweating. S stands for SOB, that is dyspnea. U stands for upset stomach. R stands for relief on rest, that is stable angina. And E stands for emotion, that is anxiety. Risk factors. Who is susceptible for CAD? Yes, there are some modifiable risk factors and non-modifiable risk factors. Modifiable ones are the hypertension, dyslipidemia, smoking, diabetes, obesity, physical inactivity and poor diet leading to the coronary artery disease. Non-modifiable ones are the age more than 45 in males and more than 55 in females, more common in male sex, the family history of CAD and genetic predisposition. Key points where the modifiable factors account for more than 90% of population at attributable risk. Metabolic syndromes like hypertension, hyperglycemia, high TGs, low LDL, central obesity are the multiple risk factors for the CAD. And family history of CAD before the age 55 in men or more than before the age 65 in women doubles the risk. Mnemonic for the risk factor is 4H plus S, that is hypertension, hyperlipidemia, hyperglycemia, homocysteine and smoking. Pathophysiology of CAD, that is how CAD progresses. Let us learn it. Lipid accumulation occurs. Second is the endothelial injury. Third is the plaque growth. And rupture and thrombosis is the last. The lipid accumulation occurs where the lipid enters, causing the macrophage and the foam cell accumulation, leading to the endothelial injury due to the risk factors like hypertension, smoking, LDL. The plaque grows fibrous cap and extracellular matrix develop. The plaque ruptures where the thrombosis occurs, and this thrombus enlarges, causing the blockage of the artery. Diagnostic tools and techniques for the CAD are ECG, where the ST changes, T-wave inversion, Q waves, and first-line acute settings are seen. Cardiac biomarkers, as same we learned in the ischemic heart disease, troponin is the gold standard biomarker, which rises in 3 to 6 hours of the infarction. Stress testing we do. Coronary angiography is the gold standard here, as we learned same in the ischemic heart disease. And CT coronary angiogram is the non-invasive alternative technique for the CAD. Treatment strategies of CAD. Lifestyle modification, medical therapy, and revascularization are the three strategies for the treatment of CAD. In lifestyle modification, we advise the patient for smoking cessation, Mediterranean diet, regular exercise, and weight control. In medical therapy, we advise the patient for the antiplatelets like aspirin, clopidogrel, beta blockers, statins like atorvastatin, ACE inhibitors like enalapril, ARBs like losartan, and nitrates. Revascularization where PCI with stenting or CABG for significant left main or multivessel disease. Mnemonic for treatment strategies is MONA-B for acute coronary syndromes, where the M stands for morphine, O stands for oxygen, N for nitrates, A for aspirin, and B for beta blocker. Complications of CAD are cardiac complications like MI, heart failure, arrhythmias, stroke, heart failure, shock, renal failure, PMR, ventricular septal defect, embolism. Critical complications are acute MI, most feared outcome of the CAD, time-dependent myocardial damage. Heart failure, systolic or diastolic, arrhythmias, cardiogenic shock, the mortality is more than 50% in it. Early recognition and rapid intervention are critical to reducing mortality. At last, I have summarized all the essential mnemonics of CAD, where the risk factors are having 4H plus S, that is hypertension, hyperlipidemia, hyperglycemia, homocysteine, smoking, and diabetes. Angina features OPQRST, that is onset, provocation, quality, radiation, severity, and time. Heart failure, that is phases, F, where the F is fatigue, activity, limitation, congestion, edema, and shortness of breath. ACS management, just we learned, that is MONA-B, is the morphine, oxygen, nitrates, aspirin, beta blockers. Key takeaways from this video and the future directions are: atherosclerosis is preventable. Aggressive risk factor modification can reverse the plaque progression. Second is time is equal to muscle. Early diagnosis, prompt revascularization save lives in acute coronary syndrome. Emerging horizons like the drugs we used and the treatment therapies and reshaping the CAD management are the key ways for the future directions of the CAD management. Thanks for watching. Hit the like button if you understood this topic and suggest me the new topic which you want in the comment section.